Today, I want to share with you a case study of a patient with functional neurological disorder that we treated here in the clinic. My name is Dr. Nathan Keiser. I'm a chiropractic neurologist. And before we get started, I should probably go into a little bit of the background about what functional neurological disorders are. We commonly abbreviate them FND for those of you that have some knowledge in this area. So I think Dr. Mark Edwards and John Stone did a really good job articulating what exactly functional neurological disorders are. So what they said was FND describes motor, so movement, and or sensory, feeling, symptoms that arise from the voluntary motor or somatosensory nervous system, and they're experienced as involuntary. So they come from, let's wind that back again, they arise from the voluntary motor system or the sensory system, and they're experienced as involuntary action. So involuntary senses, involuntary movements. And this is really important. A lot of times these are looked at like they're rare conditions. But what we actually find is they're not particularly rare. It's the second most common reason for outpatient neurology consultations after headaches. So after headaches, FND is the most common outpatient neurological consultation. So pretty important that we talk about it because they're often pretty well misunderstood, to be honest with you. And part of the reason they're misunderstood really comes from the idea that functional neurological disorders have been conflated or lumped in with other types of issues as well. We call them psychogenic disorders or conversion disorders. And what that means is those are previous diagnoses that were used to describe malingering or feigning or faking symptoms, right? And to highlight this, there's actually a study done, and you can see it here, that the results of that study showed that both neurologists and psychiatrists, when they were surveyed, considered a proportion of their feigning as intertwined with or the same thing as FND. So you can see for people that are dealing with functional neurological disorders, there's an uphill climb toward a resolution for these because, quite frankly, the toolbox is pretty small. So with that kind of background, I think it's important to kind of make a couple statements before we talk about this case. So number one, when I look at FND cases, I see a wide variety of them, and they are very frequently different treatment trajectories that we will use with them. I don't put myself out there as being any sort of a true expert in this field, but with the overlap of conditions that I treat, this happens to be part of the group of people that seek out care. And when we look at the cases very carefully, there are some components of them that make them good candidates for the things that we do. So when I show you this case, I don't want to show it as this is the treatment for all FND, all hail, go do this thing. That's not what I'm trying to say. What I'm hoping for is that if I share with you a little bit about how we looked at this case and how this story evolved over time, that we may be able to shed some light on some ideas for people that are dealing with this, for some people that are helping to treat them in practice, and maybe just provide some forward momentum in how we think about cases like this. So that's really the purpose of sharing this video, but I'm going to do it in a case story format because I think it makes it more rich to try to understand it and feel it. So the case that we're going to talk about today, I'm going to go back and forth between slides. So if I mess it up, just bear with me. But this is a case of a 17-year-old female with a history of fainting, and she was subsequently diagnosed with functional neurological disorder. The presentation of her fainting wasn't just like a faint to the floor. It was associated with a type of a pseudo-seizure where we see movement disorder component, and we see a tremor portion of this. They were happening with a relative frequency. So as you can see here from her kind of initial history that she provided, this happened several times a day, and it kept increasing They did a photic stimulation with an EEG in the hospital, which basically we hook people up to an EEG and they do a flashing light. And that flashing light helps us to be able to diagnose whether or not there is epileptiform activity in the EEG. But when she did that, she experienced a ramp up of her symptoms where she was fainting or having these episodes more frequently, and they were becoming more prolonged, and there was more of a motor component with them. So that part's important. So we'll go back here. You can see the types of episodes she would have myoclonic jerks. So jerking of her limbs and of her head. She was having difficulty walking, and this is an important one for us. She was actually drifting to the side as she walked, but she couldn't control it. She felt like her body was just carrying her over. And when most people look at something like this, it's very easy for their mind to go like, oh, that's not real. She's faking it, right? So it's really hard to be able to get a good, honest look in a case like this. So she was having times where her legs were giving out, and then obviously things were worse when she was standing up. So moving forward, the episodes typically lasted for a couple minutes at a time. But they could be anywhere up to a half an hour, an hour. And usually after it was done, she felt a sense of relief. What was interesting about that, though, was that she is nonverbal. She's not able to communicate or move, but she has a perception that she can still hear and be involved in the time scale of what's going on in the world. They're made worse with too much mental activity or too much physical activity. And then also we found in her evaluation that simply just being upright and being in orthostasis also made things harder for her. And we'll get into a little bit more depth about what that looks like. And then the only thing that helped her feel better was laying down and resting. While in the hospital, they did give her some IV saline, and that gave her several hours of relief afterwards, which gives us a clue about some of the pathology involved in this case. So that was actually a helpful little antidote. It didn't last a couple hours, felt really nice, but that's helpful for us in the diagnostic process. What's interesting about that is in that same stay, she actually interacted with a physician that was really helpful for her, that noticed that the tachycardia and palpitations that she was experiencing were mostly happening as a consequence of the orthostasis, meaning so she could lay down and get relief, she could recover, but when she stood back up again, tachycardia and then symptoms would evolve. She could lay down and again try to get to that relief period as long as it didn't go on too long and progress into the loss of consciousness phase. So super helpful, very good workup, but ultimately they kind of just ran out of tools for what to do on a solution side, and then they were recommended to see us. So part of the process that we looked at was looking at this, is kind of teasing out some of what we saw with these autonomic findings. And we confirmed what the other doctor had already noticed, and that was that she had this acceleration. Let's see if I can show you right here. This acceleration of her heart rate that happened when she was in an orthostatic position, right here, during this yellow part. So we see a baseline level of heart rate activity, baseline level of blood pressure activity, and we see a drop in blood pressure that's not on the scale of orthostatic hypotension, but it does drop and cause a requisite acceleration of the heart rate, meaning, I'll say that in easier words. So she's having enough of a dip in blood pressure that she has to have a cardiac response. So it's not as though her heart rate is just rogue on its own, taken off. It's in compensation for the fact that she's not getting adequate blood pressure, and we were able to measure that with a Doppler ultrasound of middle cerebral activity in the brain. So we were actually able to see that she was So she was losing some blood flow in her brain, which makes a lot of sense for the symptoms that she was having. We noticed that on the tilt table test, she developed some of her symptoms asymmetrically, meaning she would develop stereotypies on the right leg. She would have posturing of her head to one side. She would have fluttering of her eyes in one direction. So these are really helpful in understanding that this isn't like a global hypoxia. We're actually seeing pathway genesis where she's losing blood flow in some specific areas. So this was helpful for us. Moving forward on that, I think it's useful also to maybe, I didn't videotape this exam, so unfortunately I don't have a ton of great visuals for it. What I do have is what we looked at with oculography. And I do think that this can be helpful. So what I'm going to show you first are saccades. These saccades are eye movements back and forth, side to side. But what you'll notice, or excuse me, these are vertical eye movements, my apologies. So she's jumping her eyes to a target that's up, jumping her eyes to a target that's down, and they're randomly spaced throughout that vertical plane. And what you're going to notice is the eye movements aren't crisp and sharp like we like to see. They're actually slow and delayed. And what you'll notice in one point is you'll see her eyes do this little swirl. And that little swirl is really helpful because it helps us understand some of the integration that's happening between areas in the cerebellum and the brainstem and the frontal lobe, and this pathway that helps our eyes move in that plane. So I'm going to show you that real quick. Here we go. And you can see the way her eyes move. So you see some graphing up on the top, but I want you to watch her eyes here, and you'll be able to see these movements. So you see they're kind of slow going down, slow going up. They should snap here. Snap. Snap. See that swirl? Snap. Oh, and then her eyes drift with her head movement. So now we're starting to get, in addition to the slowing of the eye movement, she gets some movement of her head. So that drift of her eyes over to the side to the left is associated with her head turning to the right. So she's actually develops a right head turn, and her eyes drift over to the left side. So we can see these little subtle indicators that tell us these pathways in the brain are not working optimally. It's good to notice that this test is done seated, so she is in a degree of orthostasis, not just purely laying down. And then another good eye movement test that we were able to pull out is doing the same thing in that vertical plane, but now instead of using a saccade, saccades are frontally generated in the frontal eye fields. We're going to use a pursuit, which comes from a little bit different mechanism where they're generated based on information our visual system takes in and processes as a reality largely in the parietal eye fields, but in some different association complexes as well. And this is very useful because it helps us see where these two different pathways are going to intermingle to understand what's going on, what's happening here. So let's watch this one as well. Okay, so we'll play this here. The way this should move, let me back up. The eyes should go up and down smoothly in a coordinated way, no jumping, nice and smooth as they're tracking that target up and down. So you can see here, when you watch her eyes, one, they're a little jumpy, and they're jumpy side to side, which if you're following a target that's going straight up and down, there's no reason for your eyes to move side to side and do the swirls that you see there at the top and at the bottom, okay? So these are really, really helpful for us in that diagnostic process. So what we did from here, we'll just kind of share that part. So we know there's an orthostatic component to it. We see these errors in the eye movements. We see that she has a drift when she walks. She has, we didn't talk about it, but with the Maddox rod test, we see that there's the positioning of her eyes is skewed so that they don't actually, at 20 feet away, they don't actually aim at the same spot. They aim at slightly different places. And this tells us a little bit about how her brain is directing that symphony of eye movement, coordinating posture, coordinating delivering blood to her brain. So what we did, and again, as we talk about the treatment part, caveat here is this is just what we did in this case. It's not an invitation to try this on everybody you see or to try it on yourself. It's an invitation to understand how I thought about a case, okay? So don't run and do this at home. What we did was we noticed the place in her orthostasis where things start to fail. We start at the very baseline, laying flat, 0 degrees. And we worked on subtle head movements side to side or opposite of the plane where she has the hyperkinetic movement. And we just worked on having her do this simple gaze fixation, turning her head only about 3 degrees in either direction, and I did it passively. So the key for that is that if I do it for her, if I turn her head slightly and control the rotation of her spine with my hands while she looks at a target, she is not generating the movement. She's getting feedback about the movement from her body. We talked about in the very first slide how there's a mismatch between what we see, what we experience as voluntary versus the outputs from the motor system or the inputs from the sensory system. So we are commandeering the sensory system in this case. We're taking it over. And as we do that, she's able to generate these smoother eye movements. We could then bring her up incrementally, watching for the stereotypies in her legs, watching for the acuity in her eyes, and making sure she didn't fall into a convergent spasm. So we did that slowly over the course of days. And we were able to find that she could then sit up and move and walk without drifting to the side. We found that she had longer time periods between episodes, and that she was able to tolerate movement with her eyes and of a moving environment better and better and better sequentially. So an example of that, if we slide back to looking at the tests that we did, a couple days in, we repeated this test. So you can see here, this is the repeat 2. So this is the 3rd time we checked this test. And you can compare the eye movement here tracking up and down. So again, we're looking for smooth up and down eye movement. Okay. So here you can see it's not perfectly smooth yet, but you don't see any of the horizontal deviations that we saw before, and we don't see any of the swirling. So even though this isn't perfect home run yet, we can already see that these objective signs that we're looking at are starting to transfer into her experience of her subjective reality, which is awesome. So we continued that until we were able to get her to an upright position and being able to actively turn her own head. We transitioned that to then doing some exercises in our whole body rotation device, where we actually have her in a chair, goggles on similar to the ones that you're looking at here so I can see her eyes. She's fixated on a target, and we just have her rotating back and forth like this. So it's a little bit harder than me doing it, but it's still passively her body getting a stimulus of this movement. And her body getting that stimulus allowed her to attenuate or to calm down the hyperkinetic myoclonus that she was experiencing, which is beautiful. So we did this over the course of a couple weeks, and then we transferred it to tools that she could use at home so that she could get out of the wheelchair, be able to go to school, to be able to sit through class and all of the movement in class, and being able to walk to class without getting triggered by all of the sensory information, and then ultimately be able to pursue higher order education and some of the extracurricular things that she does with that. So it's a beautiful story, one that I'm super proud of her and her family for being able to execute it. But it's one that I share because there are a couple key points in that we could find these levels of orthostasis, or the fact that her symptoms are brought out by positioning where her brain doesn't understand how to get blood into the head, which further exacerbates or makes worse some of the firing rates that she experiences with the syndrome. So she has these symptoms, but the pathway that is responsible for them, when you take blood away from it, it's going to do worse. And that's what we see here. So by allowing blood flow to exist in that pathway and then slowly exercising that pathway, she was able to get some purchase. She was able to get some momentum in being able to rehabilitate that and take part in that process and solve it herself, which is pretty beautiful. So enough of me rambling. I hope it helps. Please leave comments and questions, and hopefully taking this little bit of time helps somebody. Thank you, guys.